development, of course, proceeds, lumbosacral angle appears. Yeah, so lumbosacral angle appears. Then for 3 to 4 months after birth, cervical part concave posteriorly start appearing. So if you look posteriorly, it's concave. That is the first part. Once the baby is able to stand, to start controlling their head, the cervical part concavity posteriorly start appearing. So the end of first year, that at that age, usually the child should be able to stand. In pediatrics, you'll be able to talk about the various milestones. Milestone, basically, you're talking the child should be able to start maybe controlling their head at this age. They should be able to start sitting, start crawling at this age, to start standing at this age. Those are called milestones. And some children, of course, can have delayed milestones. For example, instead of a child being able to stand at the age of 1 year, they start being able to stand at the age of probably 2 years. So that will be delayed milestone. So at the end of first year, which most students will be able to stand, the lumbar part of the curvature start appearing, which will be looking at it posteriorly. It will be concave posteriorly. So those two, the lumbar part and the cervical part, will be considered as secondary curvatures. So curves in the sagittal plane of the vertebral column for an adult that is standing in anatomical position. So cervical curvature will be posterior. We're looking at it from posterior, it will be posterior concavity. Then thoracic region, looking at it from posterior, it will be posterior convexity, convex. And then looking at the lumbar from posterior, it will be concave, so posterior concavity. Then the sacral region will be the same, and with the thoracic region, which will be posterior convexity. So you realize the cervical region and the lumbar region will be similar. They will all be posterior concavity. And then the sacral region and the thoracic region will both be posterior convexity. That is another. I think we have looked at the picture, at the diagram earlier. And then one thing you note that in pregnancy, during pregnancy, you realize during pregnancy, we have talked about the uterus that tends to be anteverted, and antiflexed. So as the uterus expands during pregnancy, the weight will tend to be pushed more anteriorly. And so this posterior lumbar concavity will tend to increase. Yeah, so there has to be increase in lumbar lordosis. So they usually in pregnancy, there is increase in lumbar lordosis. And I'm sure most of you have seen probably pregnant mothers, and you've seen that there seems to be that concavity and the lumbar seems to increase during pregnancy because of the adjustment of the weights. And then in old age, one of the things that happens in old age is that the intervertebral discs, that is the disc between the various vertebrae, which we said is a vibrocartilage, tend to atrophy. To atrophy is to become smaller. The opposite here will be hypertrophy, where they enlarge. For example, you can have a muscle hypertrophy. For people who go, for example, to the gym, the biceps muscle will tend to hypertrophy, so it become big. So the opposite of that will be to atrophy, that is become smaller, shrink. Yeah. So when they do this, when they shrink, when this, as we had said, they form around 1/4 or a quarter of the whole length will be from intervertebral disc. So it will result in loss of height, so that as people who are older are likely to appear shorter. So they are loss of weight, of height, and a gradual return of the vertebral column to a continuous anterior concavity. So they tend to go back towards that concavity that, in the fetus. So they tend to almost assume the fetal position. You've seen older people, the way they are walking with a walking stick, they are bent forward. I believe many of you. So that is the reason. As you grow older, there is atrophy of intervertebral disc and so on. And so that person start having, becoming bent forward, maybe walking with a walking stick and so on. That is basically the reason in old age. So if you look at them at the coronal plane, that is looking at them from the front. So there are some curvatures that can be seen from the coronal plane. So this basically, we have to make cuts through the coronal suture in that coronal plane. So basically looking at somebody from the front or from the posterior side. So in childhood, lateral curves in the thoracic region. So there's some lateral curve in the thoracic in childhood. Most of the time will be due to predominant use of the one upper limb. So if a child is using mainly one upper limb, the weight will tend to go towards direction, and so they'll tend to have some lateral deviation in the thoracic curvature. Yeah, so basically it's called scoliosis. So you can have abnormal vertebral curves, as we've already mentioned, where you can have kyphosis, mainly the curvature that is there in the thoracic region, we consider it as kyphosis. But usually, when you talk about kyphosis, most of the time they use it to talk about exaggeration in the sagittal curvature present in the thoracic part of the vertebral column. And some of the causes can include crash fractures, TB spine, that is tuberculosis of the spine, actually can cause collapse of the spine towards one side. And so you end up having lateral deviation. Can be because of muscle weakness, can be because of old age. That one we call senile. In old age, we can call it senile kyphosis. This is because of osteoporosis. That is basically the bones become weak or very loose, and then they actually fracture and so on. And so you end up with that large exaggeration in the sagittal curvature present in the thoracic part of the vertebra. So that kyphosis become exaggerated. So somebody is likely to look like they are bent forward. Yeah, exaggeration. That's called kyphosis. And then lordosis is looking at the lumbar region. So exaggeration in the sagittal curvature present in the lumbar region. Causes include pregnancy, as we've already said. During pregnancy, that lumbar lordosis tends to be exaggerated. Ovarian tumor, so if you have a tumor in the ovary, because it can be a very big tumor and heavy, so it will almost have the same effect that a gravid or a pregnant uterus will have. And also another cause could be vertebral column, disease of the vertebral column. So if you have disease of the vertebral column that is causing them to collapse and so on at that lumbar region, then you are likely to have that sagittal curvature in the lumbar region exaggerated, and we call it lordosis. So lumbar lordosis. Then scoliosis. When we talk about scoliosis, this one tends to be lateral deviation of the vertebral column. As we had said, for example, in childhood, the lateral curves in the thoracic region can be due to predominant use of one upper limb. And you've seen people, basically, sometimes we used to call it academic angle, people who like carrying a lot of heavy books, so they will tend to bend towards one side. We used to call it academic angle. Yeah, and so scoliosis is lateral deviation of the vertebral column. This could be because of muscular or vertebral defects. So lateral deviation of the vertebral column, it can be in any level, the thoracic or lumbar region mostly. So that is what is called scoliosis. So there are various vertebrae, which hopefully you are able to see some of them, and probably you did them even in high school. And I know you have a model there that you can look at the various vertebrae. Yeah, and most vertebra will contain this particular constituent. There will be a body, the intervertebral discs. There will be spinous processes, that is the one that will be posterior. There will be the lamina, and so on. And then we have the grooves. Yeah, and then we have articular surfaces. If you talk of superior articular surface, that is basically the one that articulates with the vertebra that is above it. And then there will be inferior articular surfaces that is able to articulate or come together with a vertebra that is below it. So we have what we call typical vertebra, then atypical vertebra. So most typical vertebra will have a rounded body anteriorly, that is in front. Then we'll have vertebral arc posteriorly. And then we have vertebral foramen. Yeah, that is, if you talk about vertebral foramen, that is where the spinal cord runs. and its coverings, the meninges. So that vertebral foramen is where now the spinal cord will be running through together with its coverings. That is the meninges. Then when we're talking of vertebral arc, consists of cylindrical pedicles, so it has pedicles and flattened lamina. And then the vertebral arc gives rise to 7 processes. There is 1 spinous process, posteriorly 2 transverse processes, and 4 articular processes. So we have 2 superior articular processes, and then we have 2 inferior articular processes, basically that articulate with the other vertebra. So 7 processes. Yeah, so our typical cervical vertebra, as we say, basically we know there is cervical vertebra, 7 of them. Then there is the thoracic vertebra, then there is the lumbar vertebra, and the sacral. Then we have the coccygeal. So looking at the cervical vertebra, there are some that are typical. So we have the first, second, and 7th cervical vertebra are considered a typical vertebra, cervical vertebra. So the first vertebra, what makes it atypical? That is the one that has a specific name. We call it atlas. That is the first cervical vertebra. It's called atlas. It has no body and it has no spinous processes. So those are the things that make it atypical. So looking at the second vertebra, that is the axis. It's called axis. It has a peg-like odontoid process. So it has a process, odontoid process that is like a peg. So that is what makes it unique. And so it's considered atypical. Then the 7th cervical vertebra also can be considered called vertebra prominens. Has the longest spinous process. So the spinous process is very long. And usually, if you're to feel your back, sometimes you're able to feel, yeah, that vertebra prominens. So I hope maybe try to mute if you, unless you should try and mute. So the 7th vertebra, what makes it atypical? It's called vertebra prominens because it has the longest spinous process, and it's not bifid. That is, if you look at that spinous process, should have bifid is like 2, so it seems to have divided into 2 for most of the others. But this one, the spinous process is not divided into 2, so it's not bifid. And then the transverse process is large, but the foramen transversarium is small. So foramen transversarium is where the vertebral artery passes through in the cervical vertebra. So its foramen transversarium is small. So those are some of the things that make the 7th cervical vertebra atypical. So typical vertebra, cervical vertebra, that is the vertebra of the neck, cervical vertebra. A typical one would have bifid. The spinous process will look bifid. You can see it as 2, almost divided into 2. It will have a lamina. It will have a pedicle. It will have a body. It will have a transverse foramen where the vertebral artery will go through. You have a transverse process. So these are typical, and this is what a typical one would look like. Yeah, the groove for spinal nerve. This is what a typical one would look like. And that's why when we talk about the atypical ones, like the first, second, and 7th, you see there is something. For example, the first one has no body or spinous process, no body or spinous process. So those are some of the things. If you have to look at a typical one, this is how a typical cervical vertebra would look like. Still another vertebra. Just the normal vertebra. The other vertebra, if you look at the thoracic vertebra or lumbar vertebra, you'll have a spinous process, transverse process, and all this. And then you can see the spinal cord there where it passes through. You can see the lamina, you can see the pedicle, you can see the body, you can see the intervertebral disc anteriorly. So basically, this is trying to show you how the relationship of the spinal cord with the vertebra. You can see around the spinal cord are the coverings. Those are the meninges. Yeah, atlas. This is the first cervical vertebra, C1. And we said is one of the vertebra that is considered atypical with no body. Yeah. You can see the transverse foramen, that is where the vertebral artery passes through. You can see posterior tubercle, posterior arc of the atlas, and you can see the facet for dens. That is where the dens now is where the axis, that ontodoint process articulates to. Yeah, the axis, you can see that's a body. You can see the dens, that is the ontodoint process. That is peg-like ontodoint process. That is one of the things that makes it atypical. The second cervical vertebra, otherwise known as the axis. Spinal process, you can see so that is the second cervical vertebra, the axis, one of the atypical vertebrae. Then the seventh, we said one of the things about the seventh is the spinous process. It has one of the longest spinous process. It's not bifid. Yeah. And then the foramen transversarum is very small. Yeah, and you can see. So it's one of the considered to be atypical vertebra, cervical vertebra. Yeah, then of course we have joints, just like we have joints in the other parts of the body. So likewise in the back, we have these joints. So atlanto-occipital, that is basically, the atlas is the first cervical vertebra. So that's why you get atlanto, then occipital. So the joint between the atlas and the occiput, that is the skull. Up there is the atlanto-occipital joint. And you can see during that joint, you can be able to basically bend your head up and even extend your neck through that. So basically, when you're doing that, most of the time it is at that joint of atlanto-occipital joint. When you look at the atlantoaxial, that is basically between the atlas and the axial axis. Axis is the second cervical vertebra, and mostly that you are able to turn your head to the left and to the right, rotating. It's because you're using that joint, the atlantoaxial joint, so that you're able to rotate your head to the right and to the left. So nodding and extending your head mostly use the atlanto-occipital joint. So when you to look at the joints below the axis, that is from below the second cervical vertebra, we have the bodies, we have between the bodies, we have cartilaginous. Remember, we have the intervertebral disc. Then we have articular processes, which are synovial. So between the various, with the processes, in the process, articular process, that is the process that join one vertebra and the other, and one below and one above. So those joints between those will be synovial. But these other one between the bodies themselves, the bodies of the vertebra, that is below the axis, they will be cartilaginous. That is intervertebral disc. Yeah, so joints between two vertebral bodies, we have the intervertebral disc, as I've already said, which is fibrocartilage, which is entwined between the plates of hyaline cartilage. So between the two vertebral arches, we have a synovial joint. You can see the intervertebral disc, and if you are to look at which is a fibrocartilage, if you are to look at the structure, in the middle of it, we have the nucleus pulposus, and then on the periphery, we have the annulus fibrosus. So those are the divisions that you will have in an intervertebral disc if you are to cut through it and look at it. So more on intervertebral disc, some details. So as I've already said, it's responsible for around 1/4 of the length of the vertebral column. That is a quarter of the entire length of the vertebral column will be formed by the intervertebral disc. If you are to add all their lengths, then you'll get 1/4 of the entire length. And generally, the intervertebral discs tend to be thickest in the cervical and lumbar regions, where movement is greatest. Just generally in your spine, most of the movement will be at the neck and at the lumbar region. Yeah, generally, if you see most of those movement, it will be there. So at that point, at the neck, cervical region, and the lumbar region, the intervertebral discs will be thickest in those areas. So they'll be thin in the thoracic region and probably the sacral region and the others. Yeah, lumbar region and the thoracic region. Um, so they are regarded, these intervertebral discs are regarded as semi-elastic discs, which lie between the rigid bodies of adjacent vertebrae. So the vertebrae themselves are bones, so they are rigid, but these intervertebral discs, as I had said, they are a semi-elastic disc. That is what makes the spine or the thoracic, uh, the column, the vertebral column, be more flexible as a whole. Working as a unit is flexible rather than it being rigid. So it serves as a shock absorber when the load on the vertebral column is suddenly increased, e.g. from jumping from a height. So if you jump from a height, these intervertebral discs are shock absorbers. So it helps you to be able to land smoothly and prevent injury. Yeah, one thing to note there, however, is that the resilience of intervertebral discs are gradually lost with advancing age. So as you advance in age, that resilience tends to be lost. So they're not as compliant as when you are young, as you grow older. As I've already said, the peripheral part of intervertebral disc is what we consider as annulus fibrosus. The central part is called nucleus pulposus. And in a child, usually it's almost jelly-like, it's almost like a gel, the nucleus pulposus. So annulus fibrosus is fibrocartilage with collagen fibers arranged in concentric layers or sheets. So concentric is round or it can be in sheets. So if you look at the nucleus pulposus in children and adolescents, it's ovoid in shape. It's a mass of gelatinous material containing large amount of water and a small number of collagen fibers and a few cartilage cells. So there is no disc sound between the first two cervical vertebrae or in the sacrum or coccyx. So in the sacrum or coccyx, there are no intervertebral discs. So intervertebral disc will be in the first two, that is the atlas and axis. Between the two, there is no intervertebral disc. But between the second and the third and so on, there will be intervertebral disc in the cervical region. Then in the thoracic region, there are intervertebral disc also in the lumbar region. But in the sacrum and coccyx also, the intervertebral disc are absent. In old age, the discs are thin and less elastic. So we already said, generally in old age, they tend to be thin and they are less elastic. So some movements that will be found in the vertebral column, as I've already mentioned, if you can do flexion is basically bending forward. And then extension is like bending backward. So that is a movement that you can get in the vertebral column. Yes, you usually encouraged to do exercise of the back, bending forward, bending backward. Lateral rotation or flexion is really bending on the on one side, bending on the other side. That is lateral flexion. Then rotation, you can rotate on your back to some extent. Then even circumduction, you can do circumduction. Maybe just remember the exercises you need to be taken through when you are in primary school, maybe when you are in kindergarten and so on. So we used to do those exercises where you can do flexion, extension, lateral flexion, rotation, circumduction. Of course, there are many investigations that we use to examine the back. Many of them already we've mentioned, and many of them would probably be similar to the investigation that we've already talked in the other parts of the body. One of them, of course, will be the lumbar puncture, which you can call it spinal tap. Lumbar puncture is, in this case, you want to get the cerebrospinal fluid for the purposes of investigations. For example, somebody you suspect have meningitis. One of the investigations that we want to do is to examine the cerebrospinal fluid. And so the way to get it is through lumbar puncture. As I said, you want to go between the fourth and the fifth lumbar vertebra, that intervertebral space. That is where you want to go. One of the things here will be safe, because you know that the spinal cord ended at around the lower border of L1. So between the fourth and fifth, you're almost sure that the spinal cord will not be there. In fact, all you will have there is subarachnoid space that is filled with CSF and the nerves. because at that point you are in the cauda equina. So you will not be able to injure the spinal cord. That is the reason. So at around the fourth and fifth, and I want to believe that when you go to rotation, like in medicine or even in pediatrics, sometimes you may be required to get the spinal fluid or CSF for the purposes of investigations. So you may be required to be able to do a lumbar puncture or a spinal tap. So you should be able to place your needle there between the fourth and fifth. And I've told you how to be able to estimate. If you look at the iliac crest posteriorly, if you are to connect the two iliac crest of the right and left, then it will probably pass between this space, between the fourth and fifth space between the two lumbar vertebrae. So you will be able to safely get the spinal fluid there. Then, of course, you can do spinal x-rays. Most of the time, we like doing them anteriorly and laterally. So most of the x-rays, you want to do two views, as I told you last time, lateral and probably anterior-posterior, and lateral view. So spine x-ray, plain spinal x-ray, you can be able to see whether there are fractures of the vertebra, because you can have fracture, you can have the vertebra affected by tuberculosis, for example, or it could be also destroyed by a cancerous process. So you should be able to see. And then you can be able to see whether the density of those bones are low, especially in old age. You'll find there's what we are calling osteoporosis. So you can be able to tell. And then you can also be able to see whether there is reduction, for example, in lumbar lordosis, or there is exaggeration of, for example, thoracic, there could be kyphosis. You can also be able to see whether there is lateral deviation, that is scoliosis. So just by looking at the spine. Of course, you can do a spine, maybe you can say a cervical spine, you just want to look at the neck. You can do also thoracic spine alone. You can do lumbar spine or even sacral and so on. Or you can do the whole spine. You can do the CT scan of the spine, especially when we want to look at the bones in details. Whether where we suspect, for example, fracture and maybe injury to the spinal cord, sometimes you need to do a CT scan of the spine. And then MRI of the spine, especially for this one, when you learn to look at the spinal cord. Yeah, you want to look at the spinal cord. There is sometimes what we call intervertebral disc prolapse. Sometimes those intervertebral discs sometimes can prolapse. And when it prolapses, because of the location of the spinal cord, it can sometimes can press the spinal cord, or it can press the nerves as they exit the spinal cord, and it can cause problem, maybe pain in the lower limb, pain at the back, and so on. So we call it prolapse of intervertebral disc. So sometimes when you want to see those ones, you can use MRI, magnetic resonance imaging, because it's able to show you soft tissues. It will still be able to show you the bones. CT scan, mainly you want to look at the bones. It will still be able to show you a bit of the spinal cord. CT scan is a computed tomography. Yes, and you can see the lumbar puncture. So that's the position somebody will sit when you want to tell them to bend forward slightly at the neck region. That one helps you open the spaces between two vertebrae. And so you are able to put the needle between, and as I talked about, the fourth and fifth space. That is where you want to look for. And then you can see the spinal cord usually end up there at the lower border of L1, so it will be safe. You will not injure it. If you go up there, then you are likely to injure the spinal cord, and that will not be good. So you want to go far away from it, where you are sure there will be just the fibers. There you are the cauda equina, there'll just be fibers and this. So you want to get into the subarachnoid space. That is where it's filled with CSF, cerebrospinal fluid. And then you can see. Of course, you can put even at between L3 and L4, still will be safe, because remember the spinal cord ends at L2. But most of the time we want to go between L4 and maybe L5. So, but L3, L4 is still safe, because you are far away from there. You can see where the spinal cord is ending. So cerebrospinal fluid is collected from the thecal sac that surrounds the spinal cord. So basically, thecal sac, that is the subarachnoid space filled with CSF, and you can see where you're putting the needle. Yeah, the X-ray of the spine. You can see this is you can see the left, the L there is showing left, so this other side is right. You can see the pelvis, and you can see the lumbar vertebra. That is looking from anterior. The left X-ray is anteriorly. Then the X-ray on towards your right is the lateral. You're taking the X-ray from the lateral side. So you're looking at those vertebrae. You can see the vertebral bodies. You can see in the lateral part, you can see the spaces between the bodies. That is where the intervertebral disc is. Because remember, intervertebral disc is a fibrocartilage. This is a soft tissue. So a plain X-ray will not show them. So you will see them as spaces. So this will help you also. You can be able to see if the space is reduced. That means probably they could be having a prolapsed intervertebral disc and the intervertebral disc that has been destroyed. So from the lateral side, you can be able to look also at the sizes of the vertebral bodies. As you can see, some of them look like they are wedge-shaped. So some of them look like they are a bit compressed. They are not as smooth as they should be. Yeah, so from the lateral and anterior look, you can be able to see some near. Then you can see from that lateral side, you see like the lumbar lordosis seems to be reduced. So that back look almost quite straight. And basically that will show probably there's a pathology. There's probably spasms of the muscle spasms of the back. So probably this is a person who presented with back pain. And this is one of the tests that we do to see whether there is any pathology. Yes, and you can see the CT scan of the spine and the MRI. On the left one side, you can see the MRI. And you can see with the MRI, you can clearly see the intervertebral disc, you can see the bodies, and even you can see the spinal cord. Yeah, that posterior, we have the transverse processes, spinous processes. So that is the MRI. You can be able to see the spinal cord and the soft tissues, but you still be able to see the bones. And then on the right side, you can see the CT scan of the spine. You should still be able to see friends from the lateral side. Both of these are from lateral views. Yeah, you can still see the vertebral bodies, but the spinal cord is not as clear, but you can see that space that where you expect the spinal cord to be. So you can still be able to discern the spinal cord. And of course, you can see the soft tissues there. You can even see the position of the umbilicus. Yeah, so an X-ray, a CT scan, MRI of the spine is something that is commonly done. So basically, that would be it. Thank you so much. So I'm really grateful for all of you. It's been an enjoyable journey.